reality in the global health. Vijay always has a special interest on viruses, and that has helped him when he was heading the lung transplant ICU in Illinois. He is a renowned researcher and has many publications to his name. He spent 6 months in Chicago and 6 months in India, where he has this NGO called Share, which deals with community health, especially infectious community health. And he's done with Mumbai BMC a TB project with the CDC. Ladies and gentlemen, we have Vijay today as a renowned researcher, a renowned clinician, but also interested in community health. And he's going to talk to us regarding COVID-19 in India, myths and realities. Vijay, over to you. Thank you.
Thank you very much. I'm going to try and start my screen sharing.
Vijay, you have to do full screen. Then
I don't know.
Okay. So start with a prayer first. Loka samastha sukhino bhavantu. Om shanti, shanti, shanti. Sare jahan mein aman aur khushiyan ho. Translates as, in all of creation may joy happen and let there be tranquility. Firstly, let me thank all of you, the Rotary Club of Mumbai, for giving me this honor and privilege of addressing you in this topic of great public health interest, the COVID. And as my father would be very pleased, because he has been a lifelong Rotarian. So for us, Rotary is always a very august and important body. Some of you will remember that many years ago, I came and addressed this august body about HIV, and probably some of you might remember the slide I showed you about the Incas and Aztecs after the Spanish conquistadors, Francisco Pizarro and Hernan Cortez, arrived in the Americas. At that time, the Incas had a population exceeding 24 million. The Aztecs had a population exceeding 24 million. The Incas had a population exceeding 12 million, a standing army of tens of thousands. And yet the Spaniards prevailed, not because they brought with them firearms that the native Indians could not combat against, but they brought something much more deadly. They brought with them measles, chickenpox, smallpox, and a whole host of other infectious diseases to which the native Indians had no immunity. A lot of people contracted these illnesses to which they had no defenses, and they succumbed. But look what happened over a 50-year period of time. Once a few of the elite died, and there were more widespread infections in the population that they had no immunity to, it led to a lot of socioeconomic disruption, and eventually led to a complete paralysis of their economy. Their social fabric disintegrated, and their population was essentially annihilated. Yet the population of the Aztecs fell to less than 4 million, and that of the Incas fell to less than 2 million, and never recovered after that. This is what is known as a demographic collapse. And this is the potential of uncontrolled epidemics in populations, particularly infectious diseases. And that's why today we are facing COVID-19. And believe me, COVID-19 may kill a few people, but it has the potential for causing widespread collateral damage by socioeconomic disruptions that will take a long time for us to recover. So COVID-19 is a new coronavirus, but coronaviruses are not new. Coronaviruses are something that we've known about for a long time because 1/3 of the common colds are caused by coronaviruses. Also, coronaviruses are very important pathogens in poultry, the infectious bronchitis virus of chicken. It is very important in animal husbandry. The porcine epidemic diarrhea of pigs are also caused by coronaviruses. So we know about coronaviruses for a very long time. The reason they're called corona is because the spike proteins that are present on the virus appear like that, like a crown. So that's why they're called coronavirus. And in the human population, the first time we saw a major serious epidemic due to a coronavirus was SARS 20 years ago, where 10% of all of the people who got infected died. Fortunately, that epidemic was rapidly brought under control. And then 10 years later, we saw MERS. Again, 30% of the people who were infected died. But again, fortunately, that epidemic was brought rapidly under control. By rapidly, I mean within the time frame of a couple of years.
Hello.
Now, COVID-19, however, has been a very different story because unlike SARS and MERS, COVID-19 has a much higher rate of replication, much higher transmissibility, and also, unlike SARS and MERS, COVID-19 has a very high viral burden in the initial stages of the infection itself. Now,
Yes.
what are the questions that arise out of this pandemic?
Yes.
How is this illness caused by COVID-19 different from the previous epidemics of SARS? The case fatality ratio is actually lower. Much fewer people who get infected die. However, the ease of transmission and contagiousness is much higher. Why did this epidemic grow so out of control? What's so unique about India compared to the United States vis-a-vis the epidemic dynamics? What's the difference between a first wave, a second wave, a third wave, and are there going to be more and more waves? What's the role of mutants and variants? Will vaccine work against new strains? Why so many deaths? Why do we have lack of oxygen in India? Why do we have lack of hospitals and trained medical staff in India? When will things improve and how? And what can we now do to address the COVID pandemic in India? A question for our elite, the government and society at large is, was the current catastrophe predictable, preventable, how, why? And can something like COVID pandemic happen again with another pathogen? How do we prevent it? What can we do to prevent anything like the COVID pandemic ever happening again? So now a few of my own personal observations. I've been taking care of patients in Hyderabad for the past year with COVID. I was in Hyderabad when the first epidemic hit, and I was in Hyderabad until 2 weeks ago, still taking care of patients with COVID. So compared to last year, an enormous increase in number of patients. Entire families coming down with COVID at the same time. This is very different from last year when I saw 1 or 2 members of the family. Now, if an entire family comes down with COVID at the same time, who's the caregiver? We all know that everyone knows a friend, a neighbor, a family member has become critically ill or has expired. I'm seeing a much larger number of patients, symptomatic patients, as compared to last year. A larger proportion of infected individuals are progressing from mild to severe illness, a much more rapid progression from mild to very severe illness very quickly. This is called telescoping. A larger proportion of individuals are taking very long to recover. Very frequent recurrence of symptomatic illness in people a few days after medications are stopped. Many individuals have presented after 1 dose of vaccine and some soon after the second dose. A number of people are having what we call the post-acute sequelae of SARS-CoV-2, predominantly chest pain syndromes, very high rapid heart rates, very disabling fatigue. And some people who ostensibly have recovered have suddenly died, and the exact cause is uncertain. We've seen an explosive increase in the demand for testing, particularly high-resolution CT scans, an explosive increase in demand for remdesivir, and there is an epidemic of treatment with what I call questionable regimens, like doxycycline, ivermectin, high-dose vitamin C, high-dose vitamin D, zinc, and so on and so forth, antibacterials, proton pump inhibitors. I will explain to you why I call them questionable regimens. There is an increase in number of patients that I'm seeing with very abnormal findings in the lungs. They did not see that last year. What's common about these people with very bad lung findings is All of them have a history of treatment with doxycycline and ivermectin for at least a week, 10 days before they have come to see me. There's been a complete collapse of public hospitals. I'm told that some people are being told to go out of the hospital and get their own oxygen somewhere else. How they're going to do that is beyond me. And some public hospitals are not consistently providing the one treatment that we know works, for which there's incontrovertible proof, which is dexamethasone and anticoagulation in addition to supplemental oxygen. So the key issues that we should be thinking about is what is evidence versus a bunch of stories strung together, which is anecdotes. What is a statistically adequate study? What are epiphenomena, which is something that occurs without any causal relationship? The importance of correct inference. Now, when I was developing antimicrobials for Abbott Labs many years ago, I always like to look at a congruence of evidence to tell me whether or not some molecule is going to actually pan out and become an antibiotic that I can get a license for. First, preclinical work. Can we show in the laboratory that it works? Can we explain in the laboratory how it works? What is the mechanism? Do we have any clinical observation data? And then finally, controlled trials are most important. There are many different kinds of trials. Equivalence means that you can show that your treatment is as good as a gold standard. Unfortunately, for COVID-19, there is no gold standard. At the very least, a non-inferiority trial shows that the new treatment is almost as good as the existing gold standard. Again, we have no gold standard for COVID-19. But what is clearly required is a superiority trial, which means that your treatment regimen must be much better, demonstrably better than anything else. Now, remember that in COVID-19, 90% of the patients get better on their own. That is the reality. It is only 10% of people who become very ill and land in hospitals, and some of them actually die. So any treatment that you are proposing must be much better, which means that that treatment regimen must demonstrate efficacy or benefit in more than 95% of the people who get COVID infections. What this means is that any kind of trial that is going to show superiority in the context of COVID has to be a very large sample size, thousands of subjects. When everything comes together, the laboratory data, the clinical trial data, then I think we have a robust data set which gives you the correct inference. And let us also remember that with COVID-19, as with other viruses in the past, this is a warning from nature that we ignore one health at our own peril. The environment, animal welfare, and human health are integrally linked. There is no way to take one out of the other. Now let's talk about some evidence. The only evidence that we have of any agent with benefit in COVID-19 is dexamethasone. The recovery trial gave dexamethasone to over 2,000 patients, and there were over 4,000 patients who were serving as controls. Dexamethasone reduced deaths by 1/3 in the patients who required a mechanical ventilator, 1/5 in patients who require oxygen but not mechanical ventilation. To date, there has been no other treatment regimen that has shown this kind of benefit, none whatsoever. Unfortunately, all of the other treatments that people are trying to push are based on small reports of small trials, none of which are statistically adequate to provide the kind of robust evidence that one needs in public health. A little bit about coronaviruses. The basic biology is very well understood because there are many different kinds of coronaviruses that infect humans as well as animals, as I reported before. The spike protein is very important for entry into the cell. And in humans, particularly with COVID-19, the key receptor that is of interest is ACE2, which is found abundantly in the lungs and also in the entire body and blood vessels, which is why the major organs that are impacted are the lungs and also all of the blood vessels throughout the body. There are other receptors, but they are probably of complementary importance to ACE2. And once the virus enters into the cell, it starts doing its work. Remember, viruses are simply a string of chemicals completely inert outside the cell. They can do nothing. Once inside the cell, they hijack the machinery of the cell to make more copies of the virus and also make smaller fragments of the virus that code for a lot of different kinds of proteins that interfere with the normal functioning of a cell and eventually cause destruction and damage. Now, what is interesting about COVID 19 is that it replicates at a phenomenal rate. Within hours, you go from a few viruses to millions and billions of viruses. At this phenomenal rate of replication, the progeny viruses that are produced are not completely exact duplicates of the original. So we have what we call genetic heterogeneity. Now, because the virus, in addition to replicating, also is translated, which means it makes smaller fragments of itself, which also recombine and reassort, that adds to the genetic heterogeneity. Now, despite the fact that COVID 19 has a proofreading exonuclease, by the time any RNA virus multiplies into billions of particles, you will have what we call a viral quasi species. What is a quasi species? This is something that Manfred Eigen proposed based on mathematical modeling in the late 1980s. He said viruses really are not just a simple species because of the enormous amount of genetic heterogeneity of a viral population. They should be considered a quasi species. The implications of a quasi species is that there is an enormous amount of genetic heterogeneity, as you can see in this cartoon. If you sample only one part of the population, you will not discern the true magnitude of all of the genetic heterogeneity. Okay. What this means is in COVID 19, it is entirely predictable that over a period of time, we will start seeing a lot of variants, what we call the double mutants, the Indian variant, the UK variant, the South African variant, and the biologic properties of these populations will be different from the original population. And we are beginning to see that. What we are seeing today is a viral population that is much more transmissible than the viral population we saw in early 2020. We are probably seeing a viral population that is probably more virulent in the sense that it has a greater propensity to cause more severe illness than the viral population that we saw in early 2020. Now, we still think that the vaccines will work for the most part, even against these variants, albeit at a lower level of efficiency. However, they are still the best tool that we have to prevent viral infections with COVID 19, and therefore, vaccines, even the current existing vaccines, must be used as much as possible. It is possible that in the future we will require slightly different kinds of vaccines, and it is also possible that in the future we may require multiple annual vaccinations to keep pace with the changing genetic nature of COVID 19 populations. Now, what happened last year is that based on some preliminary data, we at Share India did some epidemic projections using what we call an SIR model. And we projected that with a replication rate approaching 3, R naught of 3, that over a third of the population of Telangana would be infected by late 2020. At that time, everybody thought that our projections were overly pessimistic and they were not reflected in the data that we are seeing. However, here's what we are seeing today, that explosive increase. Note that the graph starts going up steeply and then suddenly goes up very, very steeply, almost vertically up. So that tells us very clearly that our projections last year were not pessimistic, they were optimistic. We projected fewer infections that we are actually seeing. So the R naught wasn't 3, the R naught is probably greater than 3. Now, what happens? An R naught of 1 means that the population virus will eventually, the epidemic will die out. As the R naught keeps going up, the slope of the increase in the epidemic goes up. This is a logistic map equation that we use in epidemiology to frequently project or calculate what will happen during an epidemic. As you can see, as the R is increasing, the slope of the curve is also increasing and becoming more and more steep. Now, what happens is with an R naught of around 3.44949, the epidemic starts oscillating around the figure. So what you see is an initial increase, then a dip, and then once again, a sudden increase again, which is exactly what we have seen. The epidemic started in India probably in very early 2020, or perhaps even in very late 2019, had an initial increase. Then there was a dip, probably in part explained by the lockdown, but then again, it started growing again and has now gone into an explosive phase. So as far as I'm concerned, this is not a second wave or anything like that. It is simply the epidemic and the natural history of the epidemic that we are seeing with COVID-19 today. Now, what happens when people get infected? To understand this, we need to understand an infection network analysis, which is basically anybody who gets infected and goes to a hospital may infect a healthcare worker. A visitor may infect a patient or a healthcare worker. The healthcare worker may infect a patient. And this way, transmission can keep going on and on. Now, how many people does one infected person infect? With SARS, what we saw is that very often one infected person would infect maybe one or two other people, but there were certain individuals who had the potential of infecting a very large number of people. These are super spreaders. So what happens is that when you have super spreading, there is an explosive increase in the numbers of people infected in a population. Now, particularly when there is a large congregation, like a big wedding or a big party, some religious gathering or election campaigns, is the probability that you will have some super spreaders spread the infection to a very large number of people goes up substantially. We call these super spreader events. So indeed, why does this happen? Because COVID is spread through the air. Now, we wasted a lot of time debating whether this is aerosol or airborne or droplets and so on and so forth. The reality is it is spread through the air, whether it's airborne or aerosol or droplets, these are all sterile debates. The implication of spreading through the air is that to prevent infection, you need fresh, uncontaminated air, or you need a very large volume of air where the virus can be rapidly diluted, which means that the most critical part of preventing infections is adequate ventilation. And this is the one part that we glossed over. Last year also, what happened is that we were petrified about the virus being transmitted from environmental surfaces, just like noroviruses. And indeed, the first few studies showed that the samples collected from environmental surfaces were PCR positive. However, PCR cannot distinguish between a whole virus and a fragment of a virus. So now we know, based on culture data, that whatever we are picking up from the environment is not easily transmissible because we don't have much viable virus there. The principal route of spread is through the air and by touching, by hands. Now, what happens once the virus gets into the body is very interesting. The body's innate immunity and adaptive immunity combine to get rid of the virus. In about 7 to 10 days, the virus is gone. So why do people get ill? And why do people become ill even 7, 10 days, 14 days, sometimes 3 weeks after an infection? Well, what happens is once the virus has infected the cell, it triggers a series of events that are ongoing and do not get switched off even when the virus is not around. The key in this is an inflammasome called NLRP3. An inflammasome is a bunch of proteins that inside the cell activates a lot of different enzymes that break down the cell, also release a lot of very noxious substances that cause what we call a cytokine storm, recruit other cells that are part of the immune system, particularly white blood cells, that can further increase the release of very noxious cytokines that cause tissue damage, and therefore the host organs are severely damaged. Now, NLRP3 is part of a very ancient system that developed to deal with unwanted nucleic acids, particularly viruses. It's an acronym for nucleotide oligomerization domain, leucine-rich repeats, spirin domain number 3. It's a very long, mouthful, scientific mouthful, but basically the best way to call it is NLRP3. Now, NLRP3 is not unique to COVID-19. We see it in a lot of different areas where there is a significant amount of inflammation causing damage to the host body. Now, what happens? Why do some people get very ill and some people not get particularly ill? It turns out that the NLRP system is quite heterogeneous in how it works. There is first an innate response, the innate immunity that deals with viral infections, primarily interferons, and these have the ability to control viral infections by activating a lot of intracellular systems. But innate responses, along with NLRP3, are probably the most potent in terms of clearing out the virus by creating adaptive immunity and antibody formation. Now, the cell, once NLRP3 is activated, also has to deactivate it so as to prevent severe ongoing damage. It turns out that in those people who have a good innate response, a strong NLRP3 regulatory capacity, they are less symptomatic, they have immunity, they develop immunity, they recover from it. On the other hand, there are individuals who have an innate response, but a very weak ability to regulate NLRP3. These people have a very severe reaction, inflammatory reaction. They actually do not develop protective immunity in the sense of making antibodies and succumb to the infection and die. So NLRP3 is the key to understanding what COVID-19 does in the human body. It's not so much the virus is gone. It is the inflammatory response of the body itself that kills individuals. Now, NLRP3 is also activated in macrophages, but NLRP3 also activates IL-18 that recruits macrophages, which are a type of white cell, very important in defense against infecting agents. But what macrophages also do is release a lot of very complex cytokines, very noxious chemicals that will also cause a lot of tissue damage. So the best way to see whether macrophages are activated is to measure the serum ferritin. If the serum ferritin is over 800 or 1000, you know that the macrophages have been activated, and you will deal with a macrophage activation syndrome causing a lot of cytokine release and severe organ damage. The other thing that happens is that COVID-19 infects all of the blood vessels throughout the body. Once the blood vessels are infected, the blood vessels are damaged. A lot of the fluid inside of a blood vessel leaks out of the blood vessel. And this is particularly important in lungs because once fluid leaks out of blood vessels into the lung, it prevents the lungs from functioning properly and your oxygen levels fall. This is the reason why also we see what we call multiple ground glass opacities in CT scans of the lungs in people who are infected with COVID. This is a fairly early event in COVID-19 infection. And this is the reason why very early on, when people are becoming very ill, we see very dramatic drops in people's oxygen levels. Once the entire vascular system is damaged, there's also activation of a lot of vascular systems that lead to blood clots, which is why 15 to 20% of people with COVID-19 get blood clots. Now, a very interesting question is, why do some people get sick and some people not get sick? Why is it that 90% of the people can recover and 10% of the people become very sick and then they die, some of them? To understand that, we have to understand what is happening in bats, because bats are the ecologic niche of a lot of coronaviruses. SARS comes from bats, MERS comes from bats, COVID-19 also comes from bats. Bats also have other viruses that are lethal for humans, like rabies virus and Nipah virus. Now, it turns out that in bats, the viral infections do not activate NLRP3 as much as they do in mammals or humans. In fact, there is a dampened response to NLRP3, which is why bats can go along living merrily with all of these viruses without dying. However, some humans who get infected with these viruses have a severe NLRP3 activated cytokine storm and organ damage and die. So therapeutically, what this means is that the ideal agent that we should use is an agent that not only suppresses viral replication, but also prevents excessive activation of NLRP3. Now, to a certain extent, dexamethasone does attenuate NLRP3 because it does attenuate macrophage activation, which is probably the reason why it works. Unfortunately, no antiviral agents that we have tested to date have done better than the host's own immune system in combating viruses. The human body, the innate response as well as the adaptive immunity reduces the viral load by more than 3 log, essentially getting rid of more than 99.9% of the virus in 7 to 10 days. No antiviral drug has done better than that, including remdesivir, favipiravir, whichever antiviral you want to use. None of them have done better than the body's own host immune system in combating the virus. Now, there is a new compound that some of you probably have heard in the lay press that the Defense Research Department organization has been talking about. This is called 2-deoxyglucose. Well, it's not exactly new. We know about this molecule for more than a couple of decades. It's initially developed to combat cancer. And it has shown efficacy in the laboratory against other viruses, particularly herpes virus, but also coronavirus, particularly the coronavirus that causes epidemic diarrhea in pigs. So there is good reason to believe that mechanistically, this drug or this agent will work as an antiviral because it disrupts the intracellular systems that are required for a virus to be transported intracellularly and replicate. But very interestingly, 2-deoxyglucose also dampens the NLRP3 response, and therefore it has a dual mechanism of action, which may be very, very interesting. However, I would still say that I would like to see a large clinical trial with thousands of subjects before I am going to accept 2-deoxyglucose as a proven regimen against COVID-19. Now, how do we prevent COVID from causing trouble in India? India, remember, is not Mumbai or Mumbai-like cities. 75% of India lives in villages. India is primarily a rural country, which means that we have to think of a strategy that is applicable in areas where there are no hospitals, no laboratories, and very little trained healthcare staff to address the problem. What we need to do is prevent COVID-19 from becoming a bigger problem. We need to prevent COVID-19 from overwhelming our hospitals and our already overstretched medical staff. The way we do that is to try and address COVID-19 in the community, in the population itself. Prevention has two different areas. One is information, good information, credible information backed by solid evidence that we have to translate into the vernacular so it is easily understood by everybody in the villages, and then focus on disseminating that with every means possible. And today we have a lot of different social media platforms that can help us. We have to promote vaccine acceptance. The other part is behavior change. And the key here is ventilation. Now, unfortunately, Indians live in small houses with very poor ventilation. There are a large number of people living in very small houses. So it becomes very, very difficult. Nevertheless, in preventing COVID-19 infection, the most important thing is ventilation, because fresh, uncontaminated air will not infect you, whereas contaminated air will infect you. This is the reason why your air conditioners and all of the other things that people talk about are completely irrelevant. What is relevant is ventilation. I open all the windows and doors no matter how hot it is in India. If you cannot assure adequate ventilation, the next important thing is masks. And it is not necessary to use N95 or nylon masks, which last only a few hours and then have to be discarded, an environmental problem. Simple cloth cotton masks will work, and they work quite effectively. If you like, you can double mask. They are very effective. You can wear them all day long. You can wash them and reuse them. The other part is physical distancing. Give everybody at least 2 yards so that they can breathe and live. Physical distancing is also important to prevent super spreader events. If you have 10 people congregating together, there's a 30% probability that one of them will get infected. This goes up to over 90% by the time you have 50 people there together. So to prevent super spreader events, we have to ensure physical distancing. Hand hygiene is very important because all viruses are transmitted through hands, as are many other bacteria. Sanitation is important. And finally, vaccination. We need to have a lot more vaccine. We have got to vaccinate over 85% of our population quickly before we have all sorts of variants that are completely immune to our vaccines. So this is the key that we have to focus on. So what we are suggesting here is that there must be a community outreach program with Dr. Chogule is actually working on with Impact India. And what we have suggested is that each outreach worker be armed with a panchastra: masks, hand sanitizer, oximeters, dexamethasone, and blood thinners like rivaroxaban. Each worker should go look for panchguna, which are the signs and symptoms suggestive of COVID, because it is not always possible to get testing with either RT-PCR or antigen testing. Oxygen saturation testing with an oximeter at rest and with exertion. Look at the weight, because a lot of people with COVID-19, particularly if they're overweight, will have serious consequences. COVID-19 is also known to trigger the appearance of diabetes mellitus de novo. So random blood sugar testing becomes important. Blood pressure becomes important because if your blood pressure is very low, you need to be put in a hospital and require intensive care. We also need to understand that any kind of public health campaign needs to be a participatory action program at a community level. So that's why it becomes very important to record the perspective of illness of the individual, the families, their society, and we need to objectively record what is the impact of the COVID problem on the entire society. It is not simply the direct infection killing a few people. It is all of the collateral damage that is occurring, the socioeconomic disruption that we are seeing, the impact on livelihood that we are seeing, that we will have to deal with for a very long time. Also, just as important, a significant number of people who have recovered from acute illness have persistent, lingering, significant disability that prevents them from earning a livelihood. And we need to understand that, support these people. At Medicity, what we have done is created a very low-cost COVID unit. Notice there are lots of windows out here and they're all open. There are lots of doors and they're completely open. So there is lots of ventilation. There is no air conditioning. There are fans, but there's lots and lots of fresh air. All of these people get oxygen, they get dexamethasone, and they get blood thinners. The cost is only 15,000 a day. That includes meals, by the way. Compare that with a private corporate hospital where they charge at least 1.5 lakh per day. This is out of reach for most Indians. So we need to focus on cost-effective methods of prevention, but we need to also provide a continuum of care where the people who require hospitalization and critical care are also provided critical care. So I will stop here and take questions. Thank you very much for the honor and privilege of addressing all of you Rotarians. Thank you.
Thank you very much, Dr. Yeldandi. That was truly extremely informative and very in-depth for sure. We have a couple of questions at the moment, and we'll start off with Mudit. Please go ahead with your question.
Thank you, Dr. Yeldandi, for your scholarly presentation. I have two quick questions without general. One is, shouldn't we have had an epidemiologist or an immunologist heading our COVID drive in India rather than other doctors? And secondly, does monsoons or rains wash away the corona virus, which is airborne, as Mumbai is going to be experiencing heavy monsoons now? Thank you, Doctor.
So I have no comment about how the COVID response is being led in India or in many other parts of the world. I think that each one of us has our own perspective on what is happening and what should be, right? In terms of whether or not the virus will be washed away by the rains, I am not sure that is necessarily true, because I think the rains will not change the amount of virus that is present in the air. So ventilation is more important than rains. What might help is sunshine. Sunshine seems to inactivate a lot of viruses, including COVID-19.
Thank you. Thank you. Can we have Satyan, please ask your question?
Yeah, thank you, Fali. Doctor, that was really informative. I have a question regarding the origin of the virus. You touched upon the bats. Recently on CNN, we had Dr. Sanjay Gupta saying that it's possible that it was actually created in a lab in Wuhan. What are your comments on that, if you'd care to
So the ecologic niche of all of the coronaviruses that we know of today that are problematic, SARS, MERS, COVID-19, the ecologic niche is bats, that they are the usual reservoir in nature. Now, the way this has happened is in the past, there has been an intermediary host. For SARS, it was civet cats and other mammals. For MERS, it was camels. And we don't understand exactly what the intermediary host was in COVID-19 or is in COVID-19. So there isn't enough data. Now, people can speculate, all sorts of speculations are rife, but I prefer to look at evidence. The evidence that we have seen so far is that this is not a virus that is a synthetic virus in the sense that it was man-made, okay? This is a natural virus. The question that arises is, from bats, how did it get into the human population? And is it possible that somebody who was playing with this virus in a lab inadvertently caused the virus to leak out into a human population? And the concern that the scientists on CNN and other places have raised is that the investigation that was led by the WHO was inadequate in answering that question. So that is the status today, as best as I understand it.
Thank you so much.
Mayank, go ahead. Mayank Kumar, please ask your question.
Yes, I had one question, is that what are the precautions and care one should take post recovery from the COVID infection, especially for people who are in their 30s, 40s without vaccination and 60 plus with vaccination, both?
So this is what I tell all of my patients who I've been treating with COVID. Firstly, they are going to stay on anti-inflammatories until all of their symptoms have resolved and the inflammatory markers in their blood have normalized. In particular, I look at the C-reactive protein, the ferritin, and the D-dimer. And some people take 1 week to recover completely. Some people take 2 weeks. Some people take 3 weeks. Some people have taken 3 months. In everybody who has what I have referred to as long-haul COVID or post-acute sequelae of COVID-19, we need to evaluate them meticulously to see what's happening. Some of them have chest syndromes, which is inflammation of the chest wall. Some of them have blood clots. Some of them have neurologic problems, cognitive dysfunction, memory problems, lack of sleep, all sorts of problems. We've seen a plethora of problems that we call the post-acute sequelae of COVID-19. It is my prejudice or my feeling that a lot of these are persistent activation of NLRP3. And you can measure that by looking at the C-reactive protein. And I think some of these people actually have ongoing inflammation of the blood vessels. And you can measure that by looking at the CRP. You can also measure that by looking at factor VIII levels and von Willebrand factor levels. So if they have all of that, then I keep them on an anti-inflammatory, and that anti-inflammatory of choice that I use is colchicine. It is cheap, it works most of the time. Very rarely has it failed in controlling this very troubling inflammatory conditions that go on and on. In early acute illness, sometimes colchicine works, but if colchicine has failed, then we add dexamethasone because that's a much more potent agent. And in those people who dexamethasone has not worked, then we are in a problem because these people by and large have severe macrophage activation syndrome, and we have to use more potent agents to switch off the macrophages. Most of the times I use a JAK inhibitor. People have also tried high-dose immune globulin, which also seems to work. Again, the problem with all of these treatments is that we do not have good, solid proof in the form of very large clinical trials. So I can tell you that this is, solid proof that you can take to the bank.
Thank you. Dushyant, please ask your question.
Yeah, thank you, President. Doctor, it's a brilliant presentation, and there was a lot of things which you learned new today. I have a question. Of course, most of us who are present here are vaccinated. But now that it's starting from 18 to 44 years of age, and since there is going to be a choice of vaccine, if you have a choice, which vaccine would you pick up? Covishield, Covaxin, Sputnik, or you would still wait for Pfizer or Moderna? I mean, your comment.
So
Your
I
comment.
I would suggest that the first available vaccine is the best. Okay, most vaccines really are equivalent. Okay, now remember that the regulatory requirement is that a vaccine demonstrate at least 50% better efficacy than placebo, all right, before it will be approved. Now, why do we say that one vaccine is 65% effective, another vaccine is 95% effective? A large part of that has to do with the time the vaccine was tested in the field. What was the prevalence of infection in the community, and what is the magnitude or difference you could demonstrate? So that are, in a way, they are mathematical artifacts, not necessarily clinically relevant to the extent that people make it out to be. So I would say that take any vaccine that you get. The earlier you take a vaccine, the higher the probability that you will have a vaccine that works against the current existing variants, because tomorrow a new variant may emerge that is really impervious to the vaccines we have today. And tomorrow we may need a different kind of vaccine. The beauty of the Moderna or Pfizer platform and the Zydus Cadila platform is that it is very easy to modify and change the antigenic requirements and the vaccine requirements. And because they are not intact viruses, they don't require BSL-3 or BSL-4 facilities to manufacture. A simple cGMP facility is adequate to manufacture. So it's faster, cheaper, and simpler to change the design of the vaccine and to produce it in very large quantities. So that is the advantage of that platform.
Doctor, only one, see, in case of a Covaxin, we are hearing they are using a dead coronavirus itself to inject, vis-a-vis Covishield, which is a chimpanzee based. So,
right.
As a layman, one would wonder that which will work better, the coronavirus itself, because that's an age-old system of creating a vaccine.
We don't see any real clinically significant differences in any of the vaccines, quite honestly. So if there are, these are very minute differences, and they are actually diluted out by the inherent genetic heterogeneity of the human population. Remember that any vaccine under the best of circumstances will be somewhere around 85 to 95% effective. Okay, you still have 5 to 15% of the population in whom vaccines simply don't work, particularly those who are immunosuppressed, right? So when you think about the pre-existing genetic heterogeneity of response, the individual differences between various vaccines pale in significance.
Thank you. Puran, go ahead.
Yeah.
Thank you.
Thank you, doctor, for the talk. I wanted to ask specifically for the time frame this vaccine will work, because we feel that if it's not going to work for many years, do you think the booster doses will come out? And if all that be the case, don't you think that the medical management is going to be far more important going ahead than taking vaccine again and again?
See, I think that we don't know how long the immunity will last. At the present time, the data suggests that you still have immunity at least up to 9 months under the best of circumstances. Different people have varying levels of immunity at varying levels of time. So when you think about COVID-19, and particularly when you think about the implications of COVID-19 in India, I think one strategy alone is not going to work. We need to combine prevention, vaccination, early treatment. What we need to focus on is save lives. Like I like to tell my residents and fellows, the prime directive is save the patient's life, because it's very difficult to treat infections in dead people.
Dr. Kripalani, go ahead, please. Please unmute yourself. Unmute yourself, please.
Audible?
Yes.
Thank you, President. Dr. Yeldandi, that was very informative. I have two questions, both about steroids. since you feel that steroids are the lifesavers, the one problem in the minds of public and doctors is on what day of the infection should steroids be given, because the personal thinking of most physicians is that steroids increase replication of virus and they also prolong the the time to disappearance. That's one question. And the
I think the internet froze there. Anyway, let me start addressing the question. See, dexamethasone in the dose that we use, about 6 to 8 milligrams a day, is what we call an anti-inflammatory dose. It really has not very significant immunosuppressive effect. And when we use dexamethasone, we don't use it in the very early part of infection. We use it only and only when people are dropping their oxygen levels. I have occasionally used it even when people have normal oxygen levels, if their ferritins are very high, because I know by that time the macrophages have been activated, and I will get into our macrophage activation syndrome. It is very important to understand the difference between an anti-inflammatory dose of dexamethasone and an immunosuppressive dose of dexamethasone. High dose steroids are immunosuppressive. We do not need high dose steroids. Remember that COVID-19 by itself is a profoundly immunosuppressive infection. Your white blood cells plummet, particularly the lymphocytes plummet, which is the reason why sometimes in COVID-19 we see tuberculosis, or we see aspergillosis or mucormycosis. And I have a prejudice that those patients with COVID who have been treated with very high dose steroids have a higher risk of getting mucormycosis or aspergillosis or tuberculosis or pneumocystis. I think that there is no advantage to giving anybody more than 6 to 8 milligrams of dexamethasone a day, because by then, if 6 to 8 milligrams of dexamethasone has not worked in cooling down the macrophages, you need to move on to some other agent, either high-dose immune globulin or a JAK inhibitor or something else like that. I think that high-dose steroids are a mistake and they should not be used. Very early dexamethasone does not appear to provide any benefit, and the recovery trial showed that in those people who don't need oxygen, there is no great benefit from dexamethasone. So I think we should be very selective in who we give dexamethasone or steroids to. Now, if we could get another agent that would be as good as dexamethasone in suppressing the inflammation and also switching off viral replication, that would be the ideal agent. Is 2-deoxyglucose going to be the answer? I don't know, but we need to ask that question and see if that is possible.
Thank you. Jaggi?
Yeah, Doc, fascinating talk. We had probably the most definitive study done by ICMR, a regulatory body, about what it came out about 3 weeks ago, where it said that after one jab, and I think if I remember from memory, they took about 90 million at that stage had taken one jab in the country. There were about 35,000 what are called breakthrough cases, right, of infections. And what was more comforting to those of us who've taken 2 jabs, it was out of 15 million, was barely 5,000 breakthroughs. So, and then obviously we were repeatedly told that the chances of serious infection are minimal, and and the usual stuff. But anecdotally and looking at the rampant spread, and I mean those one knows, and friends and associates, obviously that 5,000 number for sure seems extremely light, and I think even it's one jab equivalent, and serious illnesses. So your thoughts on that?
So that raises a lot of questions, doesn't it? I mean, the first question to ask is, how good was the entire system in maintaining the cold chain and the efficacy of the vaccine? How good was the vaccine that was delivered into the arm, right? And the second question is, all right, even though we think that the vaccine prevents serious illness and death, we know that the vaccine reduces but does not eliminate infections. Okay, but we also know that once somebody is vaccinated, even if they get infected, their chances of transmitting that infection to other people is reduced by 50%. So all in all, there are lots and lots of advantages of vaccine, and even one dose of vaccine does provide some protective immunity. It might attenuate the illness to a certain degree. To optimally immunize somebody, we still require 2 doses of most of the vaccines. There are some vaccines that are coming out that will be a single dose. So this is an evolving field. And what's amazing is this is the first time in human history that the moment a new pathogen is discovered and described, within 1 year, we have effective vaccines. That is unprecedented. The other thing that is unprecedented is our attempt to control a pandemic of this proportion by vaccination. It has called into question our capabilities in logistics, in administration, and social justice, and almost any other facet of organized activity that you can think about, right?
Thank you.
Shani, your question? Shanas, are you there?
Shani, you're on mute.
Thank you for all the information you've given us, Doctor. I was just wondering that there are cases where Covishield has given, created clots in some part of the population. So people with high PLT, should they still take it? Can they take it?
Yeah, it's a good question. See, the problem that we need to understand is that it's a small number of people who get these clots caused by the vaccine or vaccine-induced clotting, okay? Then the mechanism appears to be that the vaccine triggers antibodies against platelets, and that's why the platelets aggregate. Now, can you screen people for that kind of a problem a priori? I'm not so sure, but I must confess that is not an area that I'm very well versed in. Okay, I would have to ask somebody who's a greater expert in immunology. Now, what you need to do is keep things in perspective. 15 to 20% of people with COVID get blood clots, serious blood clots that kill them. 1% of people who take oral contraceptives, women who take oral contraceptives, get blood clots, very serious blood clots that kill them. And the blood clots that are being caused by the vaccine are, in the order of 1 in several million. Okay, so it's a very, very rare disorder. It appears that one can actually treat them. If they do get a blood clot, we do use a different kind of blood thinner, biliverdin, that seems to be quite effective in treating them and dissolving the clots. All right. Now, are there other agents that we could use and try and prevent this from happening? I think that is an area of study.
Thank you. Thank you, Doctor.
Preeti?
Good afternoon, Doctor. Thank you. That was very informative. I have 2 questions. One is, would you have any advice for generally people with very low immunity besides, as precautionary, besides following the normal protocols? Is there anything else that they can do to minimize the possibility of catching COVID? That is one. And the second thing is, for people who have taken 2 shots of one or the other vaccine, whatever it is, and then there is that given period after which you may probably the effect wears out, and you need to probably, going forward, we learn about booster doses or something like that. Now, would that be of the same kind, or would it be like you could shift from, say, Covishield to Covaxin or to something else?
Yeah, very interesting. I'll answer the second one first. So there seems to be emerging data that if you take a heterologous vaccine, there is no downside to it, and in fact, maybe an upside. All right. So in terms of what we will do in the future, this is still evolving, and I don't like to predict the future. It's a hazardous business. All right. Now, what can people do to prevent it? And this is what I tell all of my patients who are immunocompromised: get the vaccine, avoid contact with anybody who's potentially ill. So all the standard precautions like ventilation, masks, and hand hygiene. But the other thing I also tell them is what not to do. Do not take high-dose vitamin C. It's very dangerous. High-dose vitamin C is a known risk factor for kidney stones. Do not take high-dose zinc. It is a known risk factor for copper deficiency anemias. Do not take high-dose vitamin D. It's a fat-soluble vitamin. and you are risking vitamin D toxicity. You get headaches, you get hypertension, you get all sorts of problems. You get hypercalcemia, you get into trouble. So none of these things or agents that have been touted as quote unquote prevention are really things that will work. They're best described as nostrums.
Thank you. We have time for one last question. Anand Shah, go ahead, please.
Hi, doctor. Excellent talk. Very informative. I just wanted to know, in USA, when you get COVID, all they tell you is to take Tylenol morning, evening, and that's it. Whereas in India, a whole line of medicine.
Can't hear.
Can you hear me?
Anand, please speak up.
Yeah.
Can't hear.
Can you hear now?
No, not really.
You're muted, Anand.
No, he's not muted. He can't be heard.
Okay, so
Anand, go ahead.
I think I understand the question. His question is, what do people do? Right. What?
So many medicines. What's the reason?
Right. Right. So I will tell you, in India, the problem that we see is India is the wild, wild west, and every person considers himself a great expert in infectious disease, and they all start with giving all sorts of treatments. I can't really blame a lot of them. They are reacting, and unfortunately, even ICMR and All India Institute of Medical Sciences has been pushing ivermectin, which I disagree with. I think that the key is in understanding when COVID-19 is going to resolve on its own and when it's going to cause trouble. And that's a complex question. You obviously look at what's happening to people. The best things to look for is oximetry, see if the oxygen level is dropping, and the inflammatory markers in the blood, particularly CRP, ferritin, and D-dimer. So if there is an indication that there's a severe ongoing inflammation, I start anti-inflammatories. If there is hypoxemia, I start dexamethasone. So it's not, generally I do not give any of my patients acetaminophen or paracetamol because I tell them it's just low-grade fever. Very rarely do they get high-grade fever. If and when they do get high-grade fever, 103, 104, there's very often something else also going on in addition to COVID. So in the United States, what we do is a little bit different because we see if people have significant early infection and they look like they are at high risk for getting into trouble. We start out by giving the antibody cocktail because that seems to be quite effective in very early stages of infection. And then see if they need any more than that, whether or not they will require dexamethasone is contingent on what happens to their oxygen levels, anticoagulation contingent on what happens to their D-dimers and their oxygen level. So even in India, I think it is possible to practice medicine more rationally. Unfortunately, what I'm seeing is a lot of very reactive medicine. Like I said, there is an epidemic of very questionable treatment regimens.
Dr. Yeldandi, thank you very much. I know it's in the middle of the night there for you, but thank you for spending this afternoon with us. Thank you very, very much.
Great honor. Thank you very much.
Satyan, may I please request you to propose the official vote of thanks?
With pleasure, Fali. Dr. Yeldandi, thank you so much for taking time out for us. We know it's now 3:30 in the morning for you in Chicago, and you have, despite this ungodly hour, chosen to spend this time with us and enlighten us on COVID. We are truly grateful, and I think a lot of us have more clarity on the subject now. As a token of our appreciation for this time that you have spent with us, we will light up a rural household using solar power, and we will also share the certificate with you.